So welcome everyone. We've made it to week 10 in this course, and this week's lectures are all about healthcare systems. So today I'll start off by introducing different types of healthcare systems. We'll take more of a global focus, whereas tomorrow we'll really focus on the healthcare system in Canada. So that's how this week will work out. So here we go. I wanted to start off today's lecture by asking you guys, what do you do when you feel sick or when you feel ill? What kind of care do you seek and who do you interact with? So take a moment just to reflect on these three questions. And we'll start off today with a little discussion around these. So what do you do when you feel ill? What kind of care do you seek? And who is it that you tend to interact with if you go and seek care? So Cassandra says you can see a doctor or another healthcare professional if it's bad enough. Sunima says mostly just home remedies. If it's serious, I might go to a doctor. Yeah, and it might even be worth kind of thinking about it today versus maybe a year ago. So perhaps people are a little bit more hesitant given today's circumstances to go, let's say, to a hospital. Certainly, I think many of us are wary of going to hospitals now, unless it really was an emergency situation because of COVID and hearing about how some hospitals might be getting overrun with COVID patients. So that might also factor into our decision making. Anyone else? And who do you interact with? So what kind of healthcare professionals might you interact with? Cassandra says nurses. Anyone else? So nurses, family doctors. Yeah, okay. So I think you guys got it there. So there are different providers that we might interact with. That's kind of the main message here. And hopefully today and tomorrow's lecture, we'll kind of come to understand how these providers are different, what kind of different cares or treatments that we might get from these different providers, and really why is it that we might be steered towards one type of care versus another, how these treatments are all part of a bigger system of healthcare. So what is healthcare? Well, it is part of a system that brings together various institutions, organizations, people, and resources to meet the health needs of populations. And you could study the topic of healthcare in a million different ways from many different angles. In fact, many different actors are involved, different stakeholders, and they're all interested in different parts of the healthcare system. So for example, an economist might be really interested in studying something like healthcare spending and how much money is going into a system, how much GDP, for example, might it be worth. Other medical practitioners might be interested in care efficacy, so specifically looking at how effective the treatments are for a given patient and how it might impact their outcomes, something like survivorship. You know, does a particular type of treatment increase the likelihood that someone will have more kind of good quality health years of their life? That's something that they might be interested in. Now, public health researchers are often interested more in the care provision. So this just means how services, how healthcare is actually distributed across various populations, certainly across different geographies. And so no surprise, that'll be a lot of the focus for this week as well as next week when we continue talking about things like healthcare access. So that's sort of the angle that we'll be approaching it from. But of course, other experts are also interested in care efficiency. So something like wait times for treatments always do get a lot of attention, particularly in media stories, and how that might also kind of impact care and what happens in the healthcare system. So there's many different ways to approach the healthcare system. Now, there's different levels of healthcare. And so it can be thought of as operating on these different levels, and those influence what kind of treatment someone will get at each level. So the first one is primary. And at the primary level, healthcare services are usually provided either in the home or in a clinic or some kind of community health center. And they often tend to focus on more preventative treatments. So think of it from the perspective of visiting a family doctor. I wanted to ask you guys, what kind of health services do you think this might include at the primary level of healthcare? Anyone want to guess? What kind of services does primary healthcare include? Reed says physicals, yeah, so your annual kind of checkup from your family doctor, immunizations, vaccinations, yeah. Any others? Reed says PAP, yeah, so your PAP test as well. Yeah, so it includes as well pharmacies, dental care, eye care, immunization. Certainly, you guys guessed that one. Disease screening programs, so PAP tests, as well as others like colonoscopies, lung cancer screening, these types of tests. There's also smoking cessation programs, which tend to be linked as well to public health departments, but they're generally offered through sort of family doctors, or you might get referred to a program from your family doctor, and nutrition programs as well, which many public health departments do offer, again, through your family doctor. Now, what scale are these services provided at? So I guess this is kind of asking, how far would you usually travel in order to access these types of services at the primary healthcare level? What scale? Local and neighborhood. Yeah, exactly. Within your community, says Lauren, exactly. Yeah, so it's usually at the local scale. Certainly you're encouraged to seek care from the primary level at a more local source or more local scale. You certainly wouldn't want to be accessing someone else's family doctor in another city far away. Usually family doctors especially are really centralized in given regions, in particular neighborhoods. And so the idea is really that you go seek that care at the local level. Now I've put up a chart here that I thought was interesting. So this is the percentage of people without a regular healthcare provider. So this is healthcare providers, again, at that primary level of healthcare, and it's stratified by age and sex. Is there any trend that you guys notice with this particular graph? What stands out? Consistently lower in females, yeah. Anything else? Any trend by age group, perhaps? The oldest individuals have the lowest percentage. Yeah, and so remember, this is the percentage without a regular healthcare provider. So that would suggest that fewer females are without a regular healthcare provider, and fewer older age individuals are without a primary healthcare provider. So as Fiona points out, 18 to 34-year-old males are particularly the highest percentage of the population that go without a regular healthcare provider. Now, this might have some pretty important implications on health. certainly you need to see a doctor in order to receive a disease diagnosis. Something like this wouldn't necessarily capture walk-in visits, right? A regular healthcare provider is usually your consistent sort of family doctor. And so it might not necessarily mean that young males are not receiving any sort of care. It just might mean that they're not interacting with that same consistent regular doctor that they would visit on a regular basis. So this does hopefully highlight that there are some differences in how people approach primary levels of healthcare, who's included, who might not visit a family doctor or other levels of primary healthcare frequently. Now, the next level is secondary. And so healthcare offered at the secondary level can be thought of as that kind of healthcare that you would seek in a hospital setting. So this is where patients might be admitted for a particular treatment that can't take place in something like a community health clinic or your family doctor's office. Now, sometimes your family doctor is the one that refers you as a patient for treatment at this hospital. Maybe it's a particular specialist in a hospital, but other times people will also visit a hospital because of emergency or urgent care. And so what scale are these services usually provided at compared to the primary level? Usually this would be at a local or regional level. And especially if you require some sort of slightly more specialized type of care from a hospital, then your family doctor might send you to a hospital that might not be your closest hospital, but it will still likely be within your region. I do want to highlight that the number of hospitals does vary globally. And so this can, of course, impact the level of care at the secondary level that people might receive in different geographic contexts. So how does Canada compare? Canada is sort of at the lower end here compared to other similar types of countries with similar economic standing, as well as similar types of healthcare. And so what this would suggest is that there are certainly other countries in the world that have a far higher number of hospitals per million people. And so they might be perhaps more able to access this type of treatment from the secondary level of healthcare. So there are kind of these subtle differences between the number of hospitals in different places. Now, the next level of healthcare is tertiary. And so tertiary levels of healthcare are really where someone might receive more specialist type of treatments, particularly centers that are very specific to certain diseases, things like cancer treatment centers, but also others like for stroke patients, for example, that might need specialized rehabilitation. And so these are the types of facilities that are generally not available at smaller hospitals. And of course, this would impact who can go and access them or who would be referred to treatment for them. So particularly if you're living in somewhere like Canada's rural parts of the nation, certainly, then you wouldn't necessarily have access to these types of specialized treatments. And so you might actually have to travel to go and receive them. So although usually they're offered at a regional level, sometimes you do see patients who have to get referred in another province or perhaps within their province, but from another area of the province to go seek care there. So this does create some potential barriers to access, particularly if someone does have to travel a pretty significant distance in order to access care at these tertiary levels of healthcare. Now, part of what determines which level of healthcare that someone might seek, whether it's primary, secondary, tertiary, does depend on what kind of diagnosis that you have, right? What kind of disease you have will kind of determine whether or not you go see your family doctor, whether you go see an emergency room, so on and so forth. But disease diagnosis is that process of determining what a disease is based on a person's symptoms. And this is usually determined through something like a physical exam, perhaps a diagnostic test. And so there are different types of diagnoses that are usually used in order to come up with a particular disease diagnosis for someone. This might be a clinical diagnosis where a physician, a clinician, just sort of goes through a checklist of symptoms and they might say, okay, you probably have this based on sort of their expertise. Another way of coming up with that diagnosis is through the laboratory diagnosis. So this might include something like a test result. And of course, there's radiology diagnoses, and this would require something like an X-ray or other types of medical imaging. And there are other types of diagnoses that would take place. So what level of care does a disease diagnosis usually take place? What do you guys think? Would it occur at the primary level? Would it occur at the secondary level, tertiary level? Where would that disease diagnosis usually take place? So Reed says primary, secondary. Cassandra agrees. Esme says primary. Anyone else? So yeah, you guys are right. Usually it's the primary, secondary, and certainly the hope, I think from maybe an optimistic standpoint, is that a primary physician, whether that's your family doctor, maybe at a walk-in clinic, would certainly steer you to the correct level of treatment if you did require secondary treatment from the secondary level of healthcare. So hopefully your family doctor would already sort of have a hunch of what kind of care you would seek, even if they weren't the ones to specifically be able to diagnose you. Usually they would refer you to a specialist in order to do that. But this does introduce an important point that access to healthcare and treatments really does rest on the correct and the timely diagnosis of a disease. So you do really require that sort of intervention from the primary or secondary level in order to go seek further care and hopefully treat whatever disease that you've been diagnosed with. Now, can all diseases be easily diagnosed? What do you guys think? Cassandra says no. Christina says no. Seeing lots of no's. Which diseases might be particularly difficult to diagnose? Are there any examples that people know of? So Cassandra says rare diseases. Sarah says diseases with overlapping symptoms. Yeah, so non-specific symptoms. Are there any others? Elisa says fibromyalgia, so chronic conditions. Yep, anything with chronic pain. Internal diseases, degenerative diseases. Yeah, so there's numerous examples that you guys have come up with. And if not, how does this impact whether the disease and its treatments are included or excluded in healthcare? What do you guys think? If we can't effectively diagnose a disease, how might that influence treatment? So Cassandra says it could be ineffective. Sunima says some diseases that are more relevant in other parts of the world, but not as common in Canada, are often misdiagnosed. Yeah, patients might suffer for a long time. It might not be treated properly. Exactly, yeah. If doctors don't know what to do, diagnose a person with, the person might give up and stop trying to access treatment. Yeah, so there's certainly implications to not receiving correct or even any diagnosis. And Zoe says there might be less options treatment-wise. Yeah. So certainly anyone who's ill or is kind of anticipating a disease diagnosis usually waits before they try to seek any treatment or try to deal with the symptoms. They really want to receive that diagnosis in order to know how best to approach this potential disease and what options they might have in order to choose the best potential treatment course for them. Now, I do want to highlight one disease that I'm a little bit surprised didn't come up in the discussion, and this would be mental health disorders. Mental health disorders can be especially hard to diagnose because for many of them, there's really no physical exam. There's no sort of laboratory test like a blood test that would determine whether you have something like bipolar disease, for example. So we'll spend a little bit of time here talking about some of these mental health diseases or disorders. Now, this is a map of the rates of schizophrenia, or sorry, the share of the population with schizophrenia. And so remember that we said that some mental health conditions are particularly difficult to diagnose, but surprisingly, schizophrenia is not really one of them. So schizophrenia is often diagnosed by a psychiatrist, so a particular type of doctor who has training in both medicine as well as psychology and pharmacology as well, being able to treat many psychiatric disorders with pharmaceutical medication. And so schizophrenia is one of those mental health disorders that does have some pretty specific clinical symptoms. And so a doctor can diagnose usually based on cognitive or behavioral or emotional tests. Usually it is one of those diseases that does present itself with some pretty specific symptoms. And so based on that, a psychiatrist will usually prescribe treatments such as antipsychotic medication. Now, you might be wondering, what is going on in Australia? Why is the share of the population with schizophrenia appearing to be so much higher there? Well, I can tell you that it's not because everyone in Australia has schizophrenia. In fact, when you look here at the labels, you do realize that it's a pretty small proportion. But I do want to highlight that there's no single cause of schizophrenia. It's thought to be an interaction between different genes and the environment, as well as numerous psychosocial factors and other risk factors. And so these likely contribute to the risk. But what's relevant to our particular discussion is that in order to be diagnosed with schizophrenia, you do need to access care. So you do need to receive that diagnosis specifically from a psychiatrist. What does this mean? Well, any country that has access to psychiatrists or that has even universal healthcare that would allow people to really receive that treatment affordably and effectively, accessibly, it's perhaps unsurprising that people there in those types of places would have higher rates of many diseases, specifically schizophrenia, as well as other sort of psychiatric or mental health disorders. Now, what's happening likely in Australia is that Australia did come up with a national mental health strategy in recent years, and this gave much more access to care such as psychiatrists, psychologists, and other mental health professionals. And so it's likely that many people actually decided to seek care for issues that they probably had for some time. It's not that these were suddenly new cases of schizophrenia that emerged, but certainly being able to receive a correct diagnosis, being able to have access to specialists like psychiatrists would increase the rate of disease diagnosis. What's likely going on in other places in the world, to sort of compare and contrast, is that they might not have as much access to specialized care like psychiatrists. They might not have facilities like mental health facilities to effectively offer treatments. And so if there's no real available treatments, then what's the point of receiving a diagnosis? But also you do need to have a surveillance system in place. So in order to effectively track the rates of diseases, many wealthier nations do set up entire databases, health administration databases that are able to collect this data and really keep track of things. So there's many different reasons why rates of different diseases might be different in different places of the world. And certainly with something like a mental health disorder, there's many different reasons why rates might appear to be higher in some places, but it's more likely that other factors related to the healthcare system are actually at play. So let's dive a little bit deeper here. Where do people seek care for mental health issues or mental health disorders? Well, usually treatment is offered in specialized mental health care systems, but also occasionally just in sort of a general healthcare system. So when someone's having a mental health crisis, many of them will show up in an emergency room, particularly in places where there's maybe not as much access to specialized mental health hospitals. And so this would, of course, impact how people might receive treatments, specifically if they're not able to receive mental health treatments from a particular type of hospital, then that might impact how they can get treatment. And many countries don't actually treat mental health patients because they just don't have the facilities, they don't have the expertise or the resources. And so this can result in some pretty interesting gaps in treatment. And so the treatment gap percentage here just means the percentage of individuals who require care, but who are not able to receive it. So that's all it means. It's the percentage of people who are not being able to receive that mental health treatment. Perhaps unsurprisingly, places in Africa have a lot of missing data. In fact, a lot of those types of surveillance systems that we were just talking about just simply don't exist in many national settings in Africa. And also common pharmaceuticals that are used to treat many mental health disorders, things like psychosis, mania, depression, those are also not uniformly available. And so that would impact how people are able to receive treatment in different places. So this is a table showing the availability of common pharmaceuticals, particularly those that are used to treat many common mental health issues or disorders. And so you can really see just how different the availability is in some places of the world compared to others where there's likely a lot more access to experts like psychiatrists and mental health facilities and treatments. So this is to say that with any disease, particularly those that are harder to diagnose, you really might have trouble being able to access the same type of care in different places. Now, as we said, being able to receive care also does require recognition of a particular disease. So you do need that diagnosis. In particular for mental health conditions, you really do need the recognition on behalf of a doctor or some sort of health expert in order to refer you to some treatment, effective treatment. And this in itself varies around the globe. So there are many inconsistencies in terms of treatments that are available, but also the availability of clinicians. So this is a map that is showing the proportion of availability of psychiatrists. And so as you can see, many places in the world do not offer as many psychiatrists to the population as others. And the availability of that would certainly impact the treatments that would be available to people requiring care. Now, on average, 70% of the world's population has access to less than one psychiatrist per 100,000 people. So that means only effectively one or less psychiatrist is available for a huge swath of some regional population in many places of the globe. This, again, will impact the availability of mental health care, but also the likelihood that someone will seek treatment. And so where available, mental health care is still commonly provided separate from primary healthcare settings because there's simply not that availability there. And so what ends up happening is that mental health care is often available through fee for service. So this means someone will have to pay a little bit extra money in order to effectively receive care because that availability is just not included in most sort of national or universal healthcare systems. Now, someone also mentioned diseases that don't have symptoms, non-specific illnesses. So symptoms of an illness are non-life-threatening, they're non-specific, sometimes they're undiagnosed, especially things like chronic pain. Someone mentioned fibromyalgia. What kind of treatments are available to these people from the healthcare system if you can't really effectively receive a diagnosis? Well, people often have to find their own healthcare system, their own sort of treatment plan outside of the regular system, because without that diagnosis from a doctor in a traditional kind of healthcare setting, you're not really available or able to access the types of treatments from, let's say, a pharmacy, which again requires a referral from your family doctor. So what ends up happening is that many people manage symptoms on their own. Sometimes they might find alternative therapies that they find are beneficial to whatever symptoms that they're trying to manage on their own. This is particularly the case with diseases like IBS, which is irritable bowel syndrome. So IBS is one of those illnesses that tends to be diagnosed through sort of a process of elimination. And so what people end up doing is that they might go to their family doctor complaining about certain symptoms, but there's no real test for them to effectively receive a diagnosis. Usually the doctor will be testing for other things and sort of ruled out those other diseases before they come to a diagnosis. So this, of course, impacts what kind of care someone might be able to get. Without that kind of formal diagnosis, you may not be able to access treatments through regular health insurance. You might have to pay out of pocket for things like naturopathy or other types of therapies that people find to be therapeutic to manage their symptoms a little bit better. Now, I don't want to say that alternative care is bad, that we should avoid things like naturopathy. Certainly, many of these types of alternative therapies do have a place in people's healing and certainly the sort of broader healthcare system. In fact, over time, the difference between what is medical versus what is medicinal has become really blurred. So there's not necessarily that strict separation between the two. In fact, a lot of modern medicine has roots, no pun intended, in botany and many sort of traditional therapeutic plant medicines. And increasingly, pharmaceutical companies are really trying to tap into this world of plant-derived medicines. So this graph is just showing the sheer popularity of articles, particularly medical articles that have come up over time, citing the use of plants or plant compounds in articles related to pharmaceuticals and drug making. So certainly alternative care is not bad. It's just a little bit different from the traditional healthcare setting. Now, a growing number of individuals also would like access to other types of alternative care. And some of these other forms of treatments are, again, largely excluded from the traditional systems of healthcare, despite the demand and despite the cultural importance for some groups. So what do I mean by this? Well, a lot of Native American tribes in the US, as well as members of Indigenous communities here in Canada, are hoping to incorporate more ways of traditional healing into their Western treatments from physicians, but sometimes also in place of those treatments rather than alongside them. So this table here was from a study in Canada, in Vancouver, that was looking into the use of Indigenous members in Vancouver of certain traditional Indigenous-based medicines and healing practices. And what they found was that more than 50% of the people in their survey cited the use of traditional Indigenous medicines. So this does mean that people would like access to them. They're certainly using them and they find it beneficial in terms of their healing, their kind of process of managing symptoms or other diseases. Now, what kinds of traditional medicines are we talking about? These might include things like sweat lodges. They might include traditional herbs and medicines, but also healing from elders or from other members of their communities that they find to be therapeutic or an improvement to their healing. Now, the next part of today's lecture is going to be about different healthcare systems. And so if you've ever wondered how the system in Canada compares to others, this is really the goal of the rest of today's lecture. But before we compare, we do really have to understand what the different types are and how Canada differs, as well as how it's similar to other healthcare systems around the world. So the first type of healthcare system is called the Beverage System. And this system was first established in the UK by someone named William Beveridge back in 1948, so shortly after World War II. In this particular system, what's kind of unique about it is that the healthcare is funded solely by the government. It is a single payer system. However, hospitals and clinics that are owned by the government are usually paid for by the government through these taxes, through patients and citizens. Now, under the Beveridge model, usually some private healthcare institutions do exist. They're allowed. But again, the government does pay for them, as well as some of the funding that comes from people's extra kind of added employer insurance benefits. And this might cover things like pre-booked elective surgeries and some diagnostic tests, but usually any kind of emergency care or acute care would have to come from that government-funded public hospital. So really, these private institutions are sort of meant for those extra procedures or surgeries. Now, again, what's unique about the system is that most of the doctors and the specialists are employees of the government. So they're not consultants, they're not working for different clinics, they're really employed by the government. And so different countries with this model, of course, do include the UK, other Commonwealth countries like New Zealand, but also some Scandinavian countries in Europe and others. Now, the main pros of this system is that it is a pretty cheap system to care. You can imagine that if everything is sort of under one roof, it's managed all by the government, there's less money that's required for things like admin service, because it's really simple to process things like payments if it's all coming from one place. It does also offer some benefits in the sense that it's universal healthcare. So it provides treatments for virtually all services that would be required for any type of disease. But there are some cons. And so this type of system is known to not necessarily cover as many expensive drugs. Of course, if it is being funded by the government is in the interest of keeping costs low. And so any type of drugs that maybe aren't as commonly used, maybe are very expensive, they might not cover it, and people would have to often pay out of pocket for them. On average, doctors are also paid lower in this system compared to other types of systems. And again, it's because the government is really in the business of keeping those costs low. And of course, this might result in some longer wait times. And so we'll compare those as well compared to other systems around the world. Now, the next system is called the Bismarck health model. And so this type of healthcare system is different from what we just saw with the Beverage model because it's funded by mandatory health insurance companies. It's not funded by the government like we saw in the previous example. So in the Bismarck model, it's mostly nonprofit state insurance companies or multiple different types of companies where the employee and the employer are splitting costs based on a person's salary, based on what kind of premiums that they're paying for. Now, some private insurance companies might be used to charge extra. So particularly for any older age individuals that maybe want to expand their coverage to include more services versus just the sort of baseline services that might be offered with an insurance package, they might also have to pay a little bit more to receive that extra coverage. Now, in this type of system, the hospitals tend to be a mix of public and private. And what's unique is that the doctors are self-employed. So they're effectively working and they charge fees, and those fees get charged either to the public system or the private system. And essentially, it's those health insurance companies that are paying those fees. So what happens here is that there's a negotiation process that tends to happen between the insurance companies and the government, as well as those doctors who are the ones offering those treatments. Now, in this model, it's commonly used in places like Germany and Switzerland, other countries in Central Europe like Austria, I believe. Japan as well is included in this example. Now, the main pros associated with this system is that it does result in some pretty low wait times. Because people are able to pay for the treatment that they want, they don't have to wait around to be seen by their local doctor. They can go to another hospital and perhaps receive treatment faster there. Those who can pay often do get better expanded treatment because they've paid for those extra services, they've paid for that better access. Now, the main cons because of this would be that it does tend to be a little bit higher cost, certainly on the individual. If you can pay for it, then you probably are paying for it, and you're probably paying a lot of money for that expanded coverage. There's also some people who would argue that the cons around this would be that the fee-for-service model can result in overcare. What that means is that if a doctor wants to make more money, they might tell a patient that they need to stay longer in a hospital so that they make more money, so that the hospital makes more money, and that patient ends up having to pay through their insurance because the insurance can probably pay for it. So that's the Bismarck model. Now, the third type is the national health insurance model, and I've put provincial because you'll see why. So this type of system is usually a healthcare system that's funded by the government. So again, it's that single payer system. And most of the hospitals and the clinics are private nonprofit entities that are paid for by the government. So from this perspective, it's similar to that first model, the Beverage model, where the government really pays for those types of services and treatments. But what's different here is that the doctors are self-employed. So they are these types of consultants that charge fees for the service that they provide. So from that perspective, it's quite similar to the Bismarck model that we just talked about. So Particularly here in Canada, if you have a family doctor's practice, that family doctor charges fees to the government insurance program. If you're located here in Ontario, we call that OHIP. And so that's why it's certainly in the Canadian context, more effective to call it the provincial health insurance model versus national, because it really is divided by the province, and different provinces have these different insurance plans. And again, if a physician isn't a family doctor, if they work in a hospital, then usually it's the hospital that charges the fees to the government insurance program. And a doctor at a hospital might also get some extra salaries for services like teaching or for running research centers or extra time in the operating room, for example. So as you can guess, places with this type of healthcare system do, of course, include Canada, but also a few others, places like Taiwan, South Korea, and I believe Hong Kong as well. Now, the main pros of this type of system is that it is a cheaper system of care. So like the Beverage model, it is funded by government. And of course, the government wants to keep costs low. So it does tend to be a little bit cheaper to run. Another plus is that it is universal health care. And so it does cover all medically necessary services that someone might need in a particular context. Now, the main cons, again, similar to the Beverage system, it might not cover many expensive drugs. What's different in our system compared to the UK is that we do require private insurance through employers to access drugs. But what's a little bit unique is that you can access those drugs in a hospital. So what I mean by that is that if you spend a night in a hospital and you are prescribed drugs there during your stay, then you're not paying for those types of drugs. So it's a little bit different there. But one of the main cons associated with this type of system is that, again, you do have to potentially have longer wait times, certainly for those elective procedures, because in our system compared to the Beverage model, where they do offer some private clinics that would be used for those types of elective procedures, in our type of system, the National Health Insurance model, there are no private clinics like that would be used exclusively for elective procedures. So there's some subtle differences. And we'll, of course, get into a lot more detail about this tomorrow when we really dive into the Canadian healthcare system. Now, the fourth system is the out-of-pocket system. So there are many, many places in the world that do not offer universal healthcare systems. In fact, most people do have to pay out of pocket to receive various treatments. So it is worth noting that some healthcare systems do look very, very different from ours or are virtually non-existent. Now, everyone's always curious about the USA and what type of healthcare system the US has. And in truth, it's actually a bit of a mix of all of the systems that we just talked about. So in the US, healthcare is funded mostly by private health insurance companies. So it's similar to the Bismarck model from that perspective. But there are exceptions for veterans and for seniors. And so their healthcare system tends to look a little bit more like our system or the Beverage system. In the US, most hospitals, as I think many of us know, are private for-profit entities. And so they can effectively charge whatever they want for particular treatments as long as someone's able to pay for them. And similar to our system, the doctors are self-employed, so they do charge different fees for different services, particularly if they have a private practice, but also if they work in some public hospitals in the States. Now, the main pros are that you tend to have shorter wait times. Specialist care can occur without that referral from a family doctor. And so that really does cut out some of the waiting time to access a specialist physician for many treatments. And of course, you do have fast access to diagnostic testing. So if you're able to pay for an MRI, for example, you can probably get an MRI pretty quickly. No surprise, the main con here is that it is a very expensive system, particularly for premiums, for out-of-pocket expenses, but also for the government to maintain, because the government does subsidize and pay for significant parts of the healthcare system. So let's finish today's lecture just by comparing how these different healthcare systems stack up against one another. People are always curious to know, economically, how expensive are these different types of systems to run? And maybe it's surprising to learn that healthcare spending per capita and as a percentage of GDP is the highest in the US. If you're curious, Canada falls just a little bit higher than the OECD average, but certainly not as high as the US. So this is the healthcare spending as a percentage of GDP. And people are always surprised to learn that the price of medication also does vary based on the type of healthcare system. So in the US, prescription drugs are actually the most expensive out of any OECD country. Now, this is not because in the US they're not taking as many pharmaceuticals as other places. It doesn't mean that they're taking more. It just means that in the US, they actually don't have a policy in place to limit drug pricing. And so that's the main difference there. Effectively, pharmaceutical companies can charge however much they want for these medications. Now, taking a look at the health outcomes, life expectancy is generally higher in places that spend more. The exception is the US, and this could be for a number of different reasons. Certainly, healthcare access might play into it. So just because there is high quality healthcare available, it doesn't mean that everybody is able to access it in somewhere like the US. But also, perhaps unhealthier lifestyles might also be a factor here. Taking a look at the MRIs, and so this is a type of diagnostic test that is one measure of the healthcare accessibility in a country. So the number of MRI exams per 1,000 people in Canada is somewhere in the middle compared to many places. Of course, the US, because people are able to pay for them if they want to access them, the access to something like a lot of these diagnostic tests like MRIs do tend to be higher. And taking a look at the number of doctors, this again does vary quite significantly across different healthcare systems. Certainly in places like Canada and the US, which do have a similar number of doctors per capita. This is in contrast to some of those other countries where there's more doctors per population. Now, taking a look at the number of hospital beds is also a really important indicator for healthcare system capacity, right? How many people are able to be effectively treated in the healthcare system is really important. And so some of the countries with the highest number of hospital beds do include places like Germany, as well as some countries in Asia like South Korea and Japan. Unfortunately, Canada is all the way towards the bottom here. And so this issue has certainly come up during the times of COVID and just how few hospital beds are available in many Canadian hospitals and what kind of impacts that has in terms of the healthcare system potentially being overwhelmed anytime something like this happens and many people get sick at the same time. Something that's also worth noting is that Canada is pretty famous for its wait times. And this is particularly true for elective non-emergency surgeries. So things like knee replacements, hip replacements, in places like Canada, where we do tend to have fewer doctors available, fewer hospitals, certainly the wait times might be quite a bit longer. But I do want to highlight that even places like the US are not immune to this problem. So in the US, an interesting issue is coming up in certain cities. So this figure, I must have cut out the caption for it, but this figure is showing the average number of days that residents in particular cities have to wait before they access a family doctor. So just to put that into context, someone living in Boston on average might wait up to 2 months before they get an appointment with their family doctor. So just sort of worth highlighting that wait times are kind of a natural part of most healthcare systems. It just depends on the particular system and what type of doctor you're talking about. Certainly in the US, there's a lot more surgeons, and so surgeries are done pretty quickly, but of course, family doctors, there can be shortages that come up for that in some geographic contexts. Now, I want to end today's lecture just by asking, how do we deliver care in places without healthcare systems? We've spent all this time talking about different systems and how beneficial they can be, what kind of services that they can provide. But in places where this can't really happen, in fact, most nations in the world do not have a universal healthcare system. Whose job is it to step in? Is it the government? Do international aid agencies have to step in? Is it private companies who are maybe better equipped to handle this kind of issue? And in places like that, should the emphasis go towards providing more community care, so something like a local health clinic, versus building a hospital, institutionalized care? these are decisions that many countries do have to kind of grapple with anytime they're trying to expand healthcare coverage or expand the number of treatments that are available. And there's a whole lot of decision making that goes into that and how this might impact access to health care and impact health outcomes. So I'm going to end it there. And tomorrow we'll pick up where we left off and talk specifically about the Canadian context.